Most people think IVF starts with your injections, but it starts way before that. It's basically how your cycle is set up that's so important. So, today in this deep dive, Dr. Gelman and I are going to break down estrogen priming, which I know a lot of you have questions about. It's one of the most important and least discussed topics about IVF and the prep as well. So, we're going to talk about what estrogen priming does to your follicles, why it's important for poor responders and low AMH patients, and then the timing that can make or break the protocol, and actually how acupuncture can help in the priming window to help improve ovarian blood flow and follicular response. So, Dr. Gelman, how are you doing today? We're going to talk a little bit about one of our favorite topics, which is estrogen priming. You can go ahead and jump
Right,
in.
right, right. It's good to be here today. I'm Dr. Gelman, IVF MD. Hello, everybody. Estrogen priming is something that it's been out there for a while, and obviously, it's an important adjunct. In what you just mentioned, it's in patients, particularly with who are poor responders or a little older, or maybe have high day 3 FSH levels, where we know that there's asynchrony in their cycle on how the follicle developments. Because once the FSH starts to rise in the premenopausal type, patient, we know that the cycle can vary. It could actually shorten because the follicle starts to mature too quick. Because normally FSH, early in the cycle should be really under 10. But sometimes you find that in these patients where they come in for their baseline values, they're 12, 13, 14, sometimes even higher, where you already know that those patients aren't going to stimulate particularly well, at least in that cycle for sure. And they're going to have rapid maturation of follicles, which is not what you want, because you want to be able to mature
Sure.
follicles at least for a minimum of 9 days, not 10 days, and not have follicles mature so rapidly that you have to either, finish the cycle early, or, start antagonists very early and the other follicles really don't catch up. So, it becomes sort of a moot point. It becomes a terrible cycle. And, you're not going to send somebody to retrieval necessarily with one or two follicles there. You want to try to get more if you can. So estrogen priming is one of the things you do, where you actually add estrogens in the luteal phase, in the cycles before you actually start stimulation. And you start it after ovulation. Sometimes I combine it with testosterone or androgens in addition, because that's another factor that can help improve follicle maturity in the next cycle, or it helps sensitize the body to the normal hormones that occur when you mature follicles. So we add androgens sometimes. Some people even add growth hormone early like that. Um, but the idea is to sort of synchronize the follicle pool and lower the FSH without suppressing it. Because if you start birth control pills, which is what the old kind of way that we used to do things, you're shutting FSH off completely and you're suppressing the ovarian function, so you don't even stimulate. I mean, what's the point? You might as well try to sensitize the ovary, which is what the estrogens are doing, and lower the FSH and synchronize the follicle pool, so at least the egg pool that you're going to start getting now can grow in a synchronous fashion once you start the injectable drugs. Now, getting back to the other point is that the priming portion of this shouldn't be necessarily 1 month, because you want to try to recruit a better follicle pool. Maybe the eggs that haven't even arrived up to the surface of the ovary yet, you want to try to lower that FSH so that these follicles that are coming up are also getting exposed to maybe acupuncture and things that are going to improve maybe the egg quality to the best extent we can, while putting them on a good diet and stress reduction, and keeping inflammation out. And you're actually priming the ovary in addition. So you're doing two things really at once, which is really what I'm interested in doing in most patients. If I can, I try to prime them for 3 months, but if you can't, 2 months, at least something reasonable. Because patients like to get this
I
done,
think it makes
obviously,
sense because
and we don't want to rush them.
And that's the growth span of the follicle, right? The maturation, in general would be like
Exactly.
3
So you
months,
want to
right? Or from primordial to, yeah,
synchronize
mature.
a new follicle pool. You want to try to synchronize a new
Mhm.
follicle pool, not the follicles that are already up there that may not respond very well to your stimulation. You want to try to synchronize the new ones that haven't made it up there to the surface of the ovary where we can, recruit them. So that's the goal. But at the same time,
Yeah.
that's where acupuncture comes in. That's where those adjuncts come in with healthy diet, stress reduction, all that. But patients are they're very impatient, and we try to do it as long as we can, but sometimes you can only do it for a month, but or better to yet to do it for 2 months or more, and not rush it and make it more of a process because you want to be successful. You don't want to be doing this multiple times and get the same result,
Yeah.
poor result. So that's really the reason.
And it would make sense if somebody has diminished ovarian reserve, perhaps they've been low in estrogen for many, many, many months or maybe years. And now you're actually giving them, a lot of our patients say, "Oh my God, I feel so much better on this estrogen now," like symptom wise. Their bodies are like, "Oh, thank you."
Yeah,
So
yeah,
imagine, I
yeah.
just
Well,
imagine the
the main
ovaries
thing
and
is the
the
main thing
follicles
is
saying, "Oh,
well,
wow, finally."
yeah. Yeah, well, the main thing what it does is it also sensitizes the ovary. It kind of
Mhm.
restores normal function there because exposing the
Right.
ovary to estrogens and lowering the FSH restores that normal cyclicity of the FSH and the LH and those dynamics. And it doesn't surprise us sometimes during estrogen priming, patients get pregnant on their own because all that normal
Mhm.
cyclicity is restored. They ovulate, blah, blah, blah. They start the estrogen, they lower the FSH for the next cycle. So the normal cyclicity and the normal follicle development ensues, and they get pregnant. So that happens too.
Yeah.
So that may be an extra benefit of
We've
doing
seen
this.
that with our patients, actually. Yeah.
Yes,
Yep.
yes,
I think
no
we had a
question.
mutual patient we did a Q&A with, and she told us about that experience. I think, coming off of a failed IVF cycle into estrogen priming for 3 months, she did an IUI with you,
Exactly,
she got pregnant, and a
exactly.
healthy pregnancy. So, I think it goes back to giving your body what it needs, and it's kind of it differs according to different clinics. We have patients come in who are going other places that are just like, "Okay, I'm doing estrogen priming, but for 2 weeks or 3 weeks." Is that really enough? Like, is that gonna be enough to, like, have to do all these things that we just talked about? Helping with blood flow, helping the ovaries respond, all those things. So, what is your take on that? Timing, I guess.
Probably, probably. I mean, physiologically, probably not, but you never know what eggs they're going to
Uh-huh.
recruit anyway. That might have been good. That might have fertilized without estrogen prime. You know, so it's hard to say for
Yep.
sure. But physiologically, it doesn't make any sense. So the estrogen priming is a
Yeah.
very good thing. And I use it all the time. I mean, I think it's one of the important things that we do before we actually put patients through here in a lot of cases because we see a lot of patients with the exact problem where they come from another clinic. They don't even use estrogen priming. They fail. They do another cycle. They
They don't
fail.
use
They
it.
use birth
Why
control
is
pills.
that?
They fail.
Why Right.
Honestly, I don't know.
But why are
I'm
they
not
not
sure
using this?
why that's not the case. I don't know. They what their philosophy is. But
Mhm.
we're all about
And
trying
I
to
don't think that
improve
there's
things,
any
making things work.
right. And most of our patients who are seeking estrogen priming are low ovarian reserve or low AMH. So they are not going to be successful in just a general IVF setting where they're being stimulated and they're not seeing very much happening. So this is the frustration of going into a cycle and going, okay, maybe there's 2, 3 follicles or maybe zero. So in that case, we go back to what harm is it going to do for 3 months to take time off and to really try to implement these strategies of, giving your body estrogen, trying to do, things like acupuncture to help increase blood flow, um, to the ovaries, and then also working with your nutrition, that kind of preconception timeline, where we can really maximize things as much as we can. And then it
Yeah.
happens sometimes that, yes, like the body will start responding. They'll get ultrasounds and they're like, lo and behold, there's 4 or 5 follicles sometimes, or all you really need
Right.
is one, but
Exactly. I mean,
I mean, it's at least enough to do an IVF,
y-
you know?
yeah, that's the point, is that sometimes you do see more follicles being produced over there. That's definitely a factor, and you also have to convince the patient that it's not taking time off. It's actually preparing you as part of your
Right.
preparatory phase of IVF. So if you divide the IVF into a preparatory phase and a treatment phase, they understand it better, because they all think, "Oh my God, I'm wasting time. I'm wasting time." You're not wasting time. You're actually helping yourself. But also keep
Yes.
in mind that older patients who are doing this, we're accumulating better quality eggs, as best quality as we can get, but ultimately, the results are going to depend upon the age of the patient and the egg quality based on the chronological age. So, while we can't improve the actual egg,
Mhm.
we're not manufacturing brand new eggs. We're going to improve the quality of the eggs based on that patient's age and chronological age, and how old they are. And, so the success rate is really going to be determined by the chronological age. But, we may be able to help things, because that's the point. We may be able to improve the outcome to a certain extent, but we're not going to make, a 42-year-old, successful, as a 32-year-old.
But we are helping with the recruitment of those follicles, right? That maybe
That
otherwise are
that
gonna be
that's correct.
difficult to
That
recruit. That's what that's helping
that
with.
that that that's
Estrogen
correct.
suppresses the FSH, correct? And then it help.
Yeah,
So that could be
yeah,
great for
lowers it.
many people.
Lowers it.
We
Doesn't
have
suppress it.
patients in their
Lowers it.
30s. Okay. So it can help patients even I think that we're seeing patients younger and younger now that are having issues with premature ovarian failure or, they perhaps have some sort of hereditary factor and they know, okay, my mom actually, they'll say to us, my mom went into menopause in her 40s or early 40s or, that sort of thing. So we go, okay, there's maybe something a genetic component that's going into this. But what do you think is the reason that we're seeing a little bit younger women actually having issues with this, like, in your opinion?
Yeah, it's a good question. I mean, we're looking for it more. With the AMH is a relatively
Mhm.
new measurement. Now we didn't have that 15, 20 years ago, I guess, and we didn't really know. And so it's just more common to do IVF now. So I guess we're seeing it more, and in the past we didn't see it. And obviously, there was a lot of women over for many years who have normal, regular cycles, and they have a low AMH, and they never knew it, and they may not be going through IVF. So you
Mm,
don't know really the reason. But yeah, I mean, are there environmental factors? Is it plastics exposure? Is it stress? Is it who knows? We don't really know. But I think just
yeah,
because we're doing the process more, and the AMH level is so readily available, more people are doing it, we're seeing it more.
yeah. And it's really important to emphasize that this is a really customized protocol that you guys are doing. It's different for each patient, I think. You're not just throwing everybody on the same, estrogen patch and seeing what's happening. Like you're really looking into what's right for that patient. So we've had patients ask, can I just get estrogen and just do it myself? And it's like, no, you need to really go to someone that knows how to do this because you're going to also need ultrasounds and you're going to need to monitor your blood work and really make sure that you're tuned in to really what's happening with this protocol. You don't want to do too little too much and then there might be other medications you're needing in addition to this. So that's why we do emphasize going somewhere that actually knows how to do this protocol correctly, and not just, randomly getting a prescription for estrogen and trying it on your own. So
Yeah, right. Because if they start it
it's
too
and
early,
what
they're not going to help themselves. So we have to document ovulation to know that they
Mhm,
ovulated, and then we can start it, and it's precisely timed, so that the patient knows exactly
mhm,
what they're doing. Because what's the point of doing it if you're not going to do it right, and it's not going to help you? So and you're not going to take
yeah,
that time to do it wrong. What sense does that make? So we
yeah.
carefully counsel the patient on how to do that.
And what are you looking for as far as the levels that you need to see? Like, I guess, in a particular time frame, like, um, if you're that cycle, you okay, after 3 months, I see activity, or 2 months, whatever it is, like, what are you looking for on the ultrasound and the
Yeah,
lab work
I mean,
during
obviously
that time?
more activity over the baseline, so you'll be able to tell by, because I like to do those priming patients myself. This way
Mhm.
I'm familiar with their ovarian function and I know what to look for in terms of, this patient's really accumulating follicles. And I'll show them, listen, this is working. So at least we're getting to where we need to get to. And I'll show them that, directly with the ultrasound.
Mhm.
They'll actually watch it. So it's really cool. So you'll
Yeah.
see the difference from baseline. It doesn't work in everybody, but a lot of
Yeah.
people it really does.
Yeah. It's definitely worth a try. I think, when you've got such a, it's such a difficult IVF cycle when someone says, "Oh, I didn't respond. I had to get my cycle. My cycle was canceled." That's just heartbreaking, and especially when they've really like put everything they can into it, emotionally, financially, physically. So the cycle cancellation is something everybody hates to see, and
Oh yeah.
if
Yeah.
this could be something that might be of benefit, I think that it's worth a conversation, and
Oh, for sure.
definitely. Uh, we've seen it work, so we know. But it's very
Exactly.
rewarding when you see, the estrogen start to climb and you see like, "Oh, wow, there's activity on the ultrasound. There's another follicle there. There's something going on." And our end, we try to do electroacupuncture a lot of times. So we'll use that, protocol. It's a poor responder protocol that we have, that's been published in a few studies, and it's been around a little while, but basically, it involves using electroacupuncture on the sacrum and certain points on the legs. And so when they've looked at Doppler studies, they said, "Oh, look, there's more blood flow happening around the uterine and the ovarian area, and uterine arteries are getting more circulation there." So I think that, that's very important because this estrogen needs to feed the follicles and its medications need to work. And so if you can provide more blood flow and better circulation, that's
Exactly.
always a good thing when you're doing this. And also, we work obviously on stress reduction. We have patients with chronic high cortisol because now you can do these wearables. Also, there's Whoop, there's the Aura Ring. They can tell you how many hours are you spending in this fight or flight mode where your heart rate is elevated, your breathing is off, your heart rate variability is lower. So we can see, and we had a patient who's she was actually saying, "Okay, I'm in this high stress mode 7 to 8 hours a day," which is terrible for your cortisol. So if your body is signaling that's not a good time to conceive. Like, we need to run away. We're in fight or flight mode. That's actually counterproductive to doing an IVF cycle or trying to conceive naturally and that sort of thing. So we need to try to flip the switch a little bit by doing activities that encourage the parasympathetic response. So that could be doing yin yoga, doing acupuncture, doing deep breathing,
Yeah.
taking walks,
Exactly.
being in nature, all those things, to say to your brain, which communicates directly with your ovaries, and say, "It's okay. We're not running from a giant. We're actually running from a wolf. We can, we call the feed and breed response or parasympathetic response. We can activate that." And these patients also notice that their cycles are irregular a lot of times. They're very delayed sometimes because that stress response is just, interfering with that signaling. So trying to get back into, that's our job, is to try to help you, get back into that pattern where the HPO axis is working correctly, and everything is syncing up. And we work with the cycle with the estrogen priming protocols that your doctor is actually prescribing. So during the luteal phase, we might do a little bit more treatment than follicular. Maybe it's not once a week, it's twice a week during that phase. We might look at, what kind of supplements you're taking, what kind of nutrition are you doing, and what are we doing for our self care during that time, especially. So, you know, hopefully this has been helpful. I think that it's something that not everybody knows about. So we're trying to highlight these types of treatments during National Fertility Awareness Week, especially so that you can have these
Yeah.
conversations with your provider and try to get the help that you need. That's really what we're concerned with. So,
Yep.
so any
Yeah, we're
other
all about
parting
success, you know.
guidance that you'd like to
Well,
add?
yeah,
Hmm.
I was just gonna say this is all meant to improve your success, obviously, and to recruit eggs,
Hmm.
and hopefully your egg quality is good so that you get a nice normal blastocyst. That's the idea. The idea is not to keep repeating the same thing over and over again, or maybe it's gonna work. And what if it doesn't? What if it keeps not working? You gotta look for reasons. I think a lot of patients come here for that reason. They're looking for, different approaches. And this is a definite physiologic scientific approach to improving your odds and your outcome.
Hmm.
So that's why it's very important. But you got to combine it with all these factors that you were just mentioning, because that's what's going to really help you.
Yeah. It's definitely a team approach. So, thank you guys for listening. We're going to come back with another topic very soon that I think is very important, talking about GLP-1s and infertility treatment. So, stay tuned for that. And then please feel free to share this with someone who needs it. Have a great week, everyone, and we'll see you next time.